orthodontist, I cannot do anything else over here. I have to only practice orthodontics. So, so I don't call myself an orthodontist. I do a lot of ortho, but I do a lot of other works too, like Dr. Manoharan just said, like surgeries and, prosthodontics and crown and bridge work and all the stuff. So I do generate a lot of aerosols, yeah, in my practice. So that's where all these things come from, because orthodontics is mainly not generating a lot of aerosols.
I cannot do anything.
I'm sorry. Um, and this is my first time giving lecture on Zoom. I have never given a lecture on the Zoom. I normally like live audiences, so that we can evaluate how the audiences, and we can see what is that is not clear by looking at the whoever's attending their face, and I can evaluate and change the way that I can teach. But over Zoom, I really don't have that opportunity. So if you have any questions, or if something is not clear, please let me know and I can make it clear. Yeah. And well, let's start the topic then. Yeah. So I have three way of like one, how before even the patient steps inside the clinic, what are the things that we do? And then I have like once the patient steps inside the clinic, what do we do? And after the patient is done with the treatment, and what else do we do in the clinic? So those are the three things that we are doing. Yeah. Um, So this is just an interim guide for safety measures during the COVID times. So let's start with saying what is COVID? Yeah, what are the symptoms? How do we know? Yeah, so we start with that. So the symptoms of COVID include cough, shortness of breath or difficulty in breathing, fever and chills, and muscle or body aches, vomiting or diarrhea, and new loss of taste or
Anandi,
smell. Yeah.
we cannot see the PDF which you are sharing. I think we have to open it and then share it. Don't directly open from that slide.
Okay.
You have to open it separately. If you had an open format kept, then you can share that separately and then you have to return to the PPT. In Zoom, that's a problem. Are you understanding?
Yes, I
If
say.
you have an open file, you
Okay.
can, share it. Share it from a different window, then return back.
Okay. Mm, you can see now.
Yes, we can see.
Okay. So these are the symptoms of the COVID-19, right? Like cough, shortness of breath or difficulty breathing, fever or chills, muscle or body aches, vomiting or diarrhea, and then new loss of taste or smell. So this is what we are looking for when the patient comes, when we say, they have COVID-19. So let me go back to my other slide. So like I was saying, even before the patient comes into the clinic, uh, this is what we're looking. We have our staff call the patients when they make an appointment and ask them, okay, do they have the signs and symptoms of COVID? Do they have the fever, or whether they have shortness of breath, or whether they have cough, and whether they have a headache, whether they have loss of taste or smell, and if they are in contact with someone who was COVID-19 positive. And we also ask this as their age is over 60, and if they have any, lung disease, kidney disease, immune disorders, and if they have traveled somewhere 14 days, in the region affected with COVID-19. So we ask all these questions. And even if there is one S in that, we see, okay, if it's just a patient is very, like if they have kidney problem or diabetes or that, I'm not going to say don't come to the office. If they had truly some emergency, we are here to take care, But other than that, if there is any yes, we don't even make an appointment for the patient to come to the clinic. And the same question is asked when they come inside the office. We ask the same questions again to the patient. So this is a protocol even before they make an appointment to come to the office. And this is the screening log for our staff itself. So it's like every day when I go into the office or when my staff comes into the office, every day we put our date, name, we measure ourselves, the temperature. We say, okay, if we have a cough, yes or no. We have shortness of breath, yes or no. And if anything is yes, and we check, and either they ask to go home or they stay and work. So we check ourselves every day, even before we start, because I have like 10 people working for me, and we need to be safe for ourselves and our patients. So we check ourselves and we check our patient as well. So before the patient comes, we have our door signs, which says, okay, if you have cough, same thing, right? I mean, like all the symptoms that I showed you, cough, fever, chills, shortness of breath, exposure to anyone who has been ill or exposed to COVID, or who has had international travel or domestic travel, we put this as a door sign. We put it on the door with a big bold letters in red saying like, please stop, don't enter, stay. And they have to wear a mask even to come inside our clinic. So we have these are two different door signs I have in my front door before even they step inside the clinic. And I have another two door signs. This is one for delivery. I use the back door for deliveries. So patient comes in a different door, and the deliveries come in a different door. So we have that separate. I have, these are two different door signs. I put them together, but and I have another door sign which says only the patient is going to be seen for the appointment. No other person other than the patient will be seen. Like, the patient's wife or husband, or, if anybody is coming, they cannot come inside with the patient. Only the patient will be dropped off and patient will be picked after the appointment. So I have that also in front, so they don't look surprised like, oh, I want to be with her. I want to be, unless the kid is like, 5-year-old, 6-year-old. Yeah, it's like very small kids. I don't really have any adult accompaniment with the patient itself. So we put this also on our door. I have all these 4 door signs to make sure the patient knows that, we follow strict protocol in the office. So, and this is a new waiting room for the patient. So when the patient comes, I don't have a waiting room now. The waiting room now is, even then the chairs are put in like 6 feet apart. We have a couple chairs, but I don't keep it as a waiting room. It's only for patients who don't have car, they come by bus or they come by walking, because some of them live close by, they come walking. The waiting room is only for patients who don't have, vehicle. So if they drive, and if they did come, my parking lot is their waiting room. So they wait over there, and then they give us a call from the parking lot to say, oh, are you guys ready for me? So because sometimes we are backed up, the room is not ready, and we cannot put them in right away in the rooms. So now the parking lot is the waiting room for us. And once we have the room ready, then we get the patient inside the clinic. So, um, so no more waiting room, no more TV, no more. We don't have no toys for the kids over there in the waiting room. We don't have any books in the waiting room, no magazine, no brochures, nothing. It's all empty, so it's easily clean. If any patient walks in, it's like nothing there except for like couple chairs in the waiting room. And that too, we allow only patients who don't have vehicle to come and sit for just like doing some paperwork, or not like sitting there for a long time. And the chairs are put in every 6 feet apart. So this is what we do before the patient comes. This is a checklist we have. So we provide, when the patient comes in, we have to give some type of sanitation, because I don't know where they touched it, even their car door, or when they walk, or when they come in a bus, So when they, as soon as they come in, we give them hand sanitizer. So they wipe their hands with the hand sanitizer. and they have to wear a mask before they even enter inside our even inside the waiting room. They have to wear a mask. So my staff knows that. And as soon as they come, sometimes if they want to wash their hands, we do have area where they can wash their hands. And again, like I said, the chairs are 6 feet apart, and we use barriers on all the chairs. The chair is covered with plastics. So it's easy for us when we know the patient sits over there, we just remove after the patient leaves, we just remove the plastic and wipe it with Clorox. So again, like I said, no toys, no reading materials, no remote control, nothing in the front. They cannot. It's not like entertainment room anymore. Yeah. So we regularly wipe the table, chairs, doorknobs, light switches, hangers. They usually don't touch any of those stuff, but still, it's like we still keep wipe. The doorknobs are the main ones that get dirty. And we do have an area where if they want to wash their hands, where they can wash their hands with soap and water. Okay, this one I'm gonna. So this is till now is what what we do even before the patient enters into our office. So I'm going to open up another PDF. So this is what we actually send the patient, as a text or email or, we whatever I said right now is there all together in this. So before the appointment, we make sure our patients are healthy. So we call them and we do the checklist that I told you. And then they wait in the car. And when the room is ready, then we call them to come inside the room. And only the patient is supposed to come inside, not anybody else, no accompaniment with the patient. And we have everything clean. They wipe clean, everything is cleaned even before or they go. And at the appointment, definitely they have to wear a mask. And then we measure their temperature, and there is nothing in the waiting room. And we have extra protection gear for ourselves, so they know. And after the appointment, if the patient develops the symptoms 2 days of their appointment, they call us and let us know, we have a COVID symptom. So we take appropriate steps so we can say this to other people who were there at the time, like our staff. And even if there was like one other person, we don't let them come across with each other, all our patients. But just in case who are there at the time period, we have to report and tell them to quarantine themselves for like a couple of days. So we have that. We have a checklist for them. Yeah. So this is what we email our patients before they even come to the appointment. So now the patient comes in, right? When the patient comes in, again, like I said, we check the temperature. So my staff wear the gloves and share. They wear the gloves and they check the temperature. So I have it like a small cheat sheet for them so that my staff don't have to remember what is the normal adult temperature and what is the children's normal temperature. So it's all easy. We make it easy for them. So the alcohol wipes is once they check the temperature, even though it's a touchless thermometer, they still wipe it to keep it clean because we are being 6 feet close to the patient. And this is the infrared thermometer that I have. It's very easy to use. So just like one click button and it reads. And also we have this glass plastic that before the window was fully open. So during the COVID times, we wanted to protect our staff as well. So I put all these plexiglass. It's like a thick sheet of plastic, which is screwed into the sides of the wall. So even the middle, it looks clear, but it is fully plastic. From side to side, it's fully plastic. So even if the patient is standing over there and talking, there's nothing, there is no uh, ballistic aerosol that comes from the patient to my staff who's sitting in front over there. So I have another glass. We have two reception areas. So both of them are fully sealed. So the only thing the patient can do is underneath, you see the small space, just enough for a clipboard. So only a clipboard can go in and then come back. So to sign the consent forms and patient registration forms. So it's very, very small area. So we did this, so it's all fully protected. And uh, uh, if we see the patient cough or something happens, we have the Clorox wipes and Cavi wipes. They're very strong wipes. The Cavi wipes is usually used after the patient to clean up everything at the back office. The Clorox, we use it in the front because it's not as strong as the Cavi wipes. So it's used to clean up the plexiglass that I showed you, or the countertop, the pen the patient wrote on. Most of the time we give the pen away to the patient, whichever pen they use, but the clipboard is wiped away. And so we use these in the front as well, even before the patient, after the patient gives it to us. So again, like I said, the chair is covered with fully plastic. I know we were reducing plastic in California. Now, with this COVID, I mean, like, we can't keep spraying chemicals everywhere and wipe with chemicals everywhere. So we started using plastic back again. And once the patient sits over there, it's only one plastic per one patient. So as soon as any patient sits over there, my staff goes and removes the plastic and cleans up with a Clorox wipe, and then they put another plastic on top, and discard the other plastic in trash. So every chair is covered with the plastic. And this is a dental chair which is covered fully with plastic as well. And all of them, we have Sharon Raw plastics covered fully. So it's again, like I said, everything is single use. We cover with plastic. Once the patient is done, we remove the plastic and then wipe. If it is the back office, we wipe with, because we have aerosol, we wipe with the Cavi wipes. If it is the front office, we wipe with the Clorox wipes. So now this is till the patient gets over here, right? Once a patient gets over there, then we have to sit them in the dental chair. I, again, avoid sitting them in too many chairs. So no waiting room chairs unless it's needed. Other than that, they go directly, once they come in, they go directly to the treatment room, the treatment chair, where they sit. So as soon as they sit, then we follow what we do inside the clinic after the patient comes in. The first thing is, of course, a hand hygiene, right? Washing hands is what, staying 6 feet apart and washing hands and wearing a mask. So the hand hygiene is very important. So there are three things that can happen. One is just soap and water. The other one is antimicrobial soap and water. Then the other one is an alcohol-based hand rub. So hand rub is nothing but the hand sanitizer. So the best is, of course, soap and water. And you can either use soap and water or antimicrobial soap and water. It doesn't matter. Just enough time to wash your hands with soap and water, like 15 seconds at least. Create yourself a song. I sing like a small song for myself and I time myself. And till the song is finished, I keep washing my hands, because it's like just you tell your patients, oh, you have to brush 2 minutes every day. In the morning, 2 minutes at night, but the 2 minutes, you don't know how long they are brushing. So you need like a timer. When you have a timer, you know that they're brushing for 2 minutes, not just 30 seconds. Basically, the statistics says the patient brushes for only 30 seconds most of the time, which is not enough. Same thing with washing hands. If you don't give enough time to wash the hands, then you're not doing a good job. So you need at least 15 seconds to wash hands when you're doing normal work, and 20 seconds to wash hands when you're doing any surgical work that requires more hand hygiene. So soap and water or antimicrobial soap and water, they both work well for washing hands. And if your hands are dirty with some soil, dirt, blood. We normally don't get as much blood bodily. I mean, we have gloves anyway. So, but just in case something happens, then you don't use the alcohol-based hand rub. You wash your hands thoroughly, like at least 20 seconds with antibacterial soap and water, or just soap and water works very well. The alcohol-based hand rub is like 60% ethanol and 70% isopropanol is what is used for alcohol-based hand rub. So please look at those. Sometimes they don't put enough alcohol in the alcohol-based hand rub. Yeah, they both work, because as soon as a patient comes inside the office, we give them the alcohol-based hand rub, the hand sanitizers, because we don't have the washroom as soon as they enter. So once they enter, then they can come inside and wash their hands in a different sink. But as soon as they enter, I provide them hand sanitizer. So even to give up pens or clipboard, so their hands are clean enough to work with whatever we are giving. So hand hygiene is very important. And like I said, 15 seconds for regular dental work is enough. 20 seconds for any surgeries that you're going to do. Yeah, 20 seconds to wash your hands. And we have automatic faucet which stops by itself when the water is, so we don't have to touch again the faucet for it to stop. We put our hands in, the water comes, and then we take our hands out, the water stops. So I have made it automatic so we don't have to touch it. Of course, all my staff needs to have their fingernails short, no artificial nails, and we avoid hand jewelry, which tear the gloves. So, that's just all basic things when you wear gloves. So fingernails, we don't allow fingernails or nail painting or, so just keep it clean. Yeah. So that's the hand hygiene, washing hands. And after washing hands, we put our gown. I like this gown which can be tied to the back. This is a very easy, nice design, because most of the time our soil, where it gets soil, is more in the hands, and in the front over here. This is where it gets dirty. So if you have a front button, the area which gets dirty is the front, and we don't want to touch our hands afterwards in the front. So if it's at the back, it's easy to take it off and throw it away. So I like this design much better. Because it has cuff in the hand. You need cuff in the hand. It's not just the open hand like these. It's not like an open hand. You need cuff so it is tight around your wrist. Yeah. And this is the other jacket I told you about. I don't like these as much because you have to open it in the front, and if it gets soil, it mostly gets soil in the front, and this is not a very good design for the lab jacket. And after the gown, after we wash our hands, then we put our gown, then comes the mask. So the mask, there are the N95 mask, the KN95 mask, and the surgical mask. So wherever you create aerosol, we recommend the N95 and KN95 masks, whichever is available. They both are, very good, nice fit, can be achieved. The surgical mask is for mostly my front office, because they have the glass covering in the front. They don't really need the N95 mask because they are not in too much contact. They always stay up inside the room, and the patient is staying outside the plexiglass. So they are not really in close contact. So surgical mask is enough for my front office. But you have to use your judgment, whether you want to give N95 to your staff, the front office, then so your administrative staff can have N95 mask. But I offered, but they had a really hard time talking with the N95 mask. So they preferred the surgical mask. So I let them choose what they want to do, because there's no aerosol over there. And, if they're comfortable with that, I was okay with that. But the back office always wears the N95 masks who are working with me at the back. So they cannot enter the room without the N95 masks. So the N95 mask, you need to pinch your nose, and then, it comes with the two rubber bands at the back, and it needs to be put in such a way that everything is fully sealed. Your nose, mouth, everything is fully covered and sealed. And we do a test after we put the mask, you have to test. There are two tests that you can do. One is the positive air pressure and the negative air pressure. That means you put the mask in your face and then you breathe. When you breathe in, there shouldn't be any air leak going inside. Or then you can breathe out. When you breathe out, you shouldn't have any air leak outside the mask going out or in. So that's the way to test your N95 masks. But with the KN95 mask, there's no test, fit test like that. But with the N95, we do have to do a fit test to make sure there is no leak. Everything is fully sealed on a nose and mouth, and it's fully protected. The other thing with the masks is it is so hard to get nowadays. It's much better now, but when it first started, it was so hard to really get masks. So we started to do like an extended use and reuse of these masks. That means extended use mean like once I don the mask, I do not take the mask until the end of the day, or if I have to have lunch or use the restroom, I just take it off in such a way. I'll show you how to take it off, take the mask and put it on. We take it off and put it in a separate area where it doesn't get contaminated. I have my own spot. Everybody in my office have their own spot where they put their mask, their gown, their shield. It's not hanging around anywhere in the office. Everybody gets their own spots. They know which is theirs. And if they have to use the restroom, they go to the rest, they take it off in the way that I will show you. And then they come back, wash their hands, and put them on back again. So these masks, we just don't throw away after every single patient. The surgical masks, of course, we throw it away every single patient if I'm using it, but not the N95 mask. So we wear it for the whole day. And I did some research, and if you could put it in paper bags, I have like 4 masks in paper bags in different containers. And I put that mask in each container for every week. So like if I use one on Monday, I use the same one the next Monday. So it's like after I wear it, like I give a whole week for it. So whatever virus or bacteria is there, and it's stored in a paper bag, and it's stored separately. And again, like I said, I have my own spot. Each and every of my staff has their own spot where they keep these masks. So we can do extended use and reuse. We can reuse these masks, the N95 masks, for 4 to 5 times. That's what it says in their criteria, right? This is about the masks. And this is how the masks look, the N95 mask. It has one rubber here, one rubber here, not on the ear. It goes on the back. Yeah. And this is another type of mask. So you can see how you have to seal the nose, mouth, and everything needs to be sealed. And after we wear our mask, we wear our shield on top of it. First comes the hand wash, to recap. Then we wear our gown. After we wear a gown, we wear our mask. After we wear a mask, then comes a shield. So this is a regular shield which goes on the head, and it covers a little bit of my head. It has like a small crown. It covers the head, and then it covers till my below my chin, the shield. So and this is the way to put the whole PPE that I talked about. First, you wear your gown, then you wear the mask or the respirator, then we put our goggles or the face shield, then comes the gloves. So this is the proper way to put your PPE. So we don't mix it. First comes the gown, then the mask, then the goggles, and then the gloves. And when you wear the gloves, make sure that you put above the cuff, right? That's why you need to have the cuff, and then it needs to be worn above the cuff. The way to take off the PPE, the dirty PPE, is like first the gown and the gloves come off together. So the gown comes off with the gloves and throw away in the trash. And then comes your goggles or the face shield. Then if you really have to reuse your mask, like I said, we use it for we reuse and we use it for extended time. After I remove my goggles and the face shield, which are dirty now, right? Because I touched it. So again, we wash our hands 15 seconds with soap and water. And then we remove our mask and put it in a place where it's only mine and I'm the only one who can take it. Yeah. So I put it there and then I wash my hands again. So that I can reuse the mask. So this is the way to take it out. First is gown and gloves comes off together. Then comes the goggles and the face shield. Then comes the mask or the respirator, whichever you're wearing. But if you're going to save your mask, again, like I said, before you touch your mask, after you remove your face shield, wash your hands with soap and water. Then take your mask off. Again, you wash your hands. Yeah, this is the proper way of putting on your PPE and removing your PPE. So now, after we put the PPE, we have to see the patient. We saw how before the patient comes inside the office, what happens. Now the patient is here, then you don yourself your PPE, and then now you have to see a patient. This is still, we haven't even seen the patient, right? So then I have to clean up the aerosol. I have this air purifier. This has a HEPA filter in it, and it runs in, it has small wheels, as you can see. It can go from room to room. So I have this connected with two rooms, so I can move it from one room to the other. I have another one in the other rooms. So uh, this is supposed to purify the air in the room within 10 minutes. So, but my rooms are not as big, so I can reduce the time to I have reduced my time to 5 minutes in the operatory, because that is a very huge machine that you can see over there. It's kind of tall and big. So per the instructions of the manufacturer and the cubic feet of the room that I have, I can use it for within 5 minutes, it will purify the air in the room. But even when I'm working, I don't off it. It runs the whole time when I'm generating aerosol in the room. It runs the whole time whichever room I'm in. So I don't wait for me to finish and then start using it. So it has a timer on it, and it picks up, this machine is supposed to pick up all the particles. So there's coarse particles, fine particles, and ultrafine particles, which, in the aerosol that generates this, all these stuff. So you can see the coarse particles, the pollen or mold, fine particles, the bacteria, dust, household dust, and also the aerosol that we generate. Yeah. And the ultrafine particles are the viruses, tobacco smoke, soot, pet dander. So they are very, very small ultrafine particles. And the filter that I have, the HEPA filter that I have, it says it will filter even 0.003 microns. And the micron particle for the coronavirus is like 80 to 120. So it actually is much better and efficient in cleaning up the coronavirus particles. So that's the reason why I got that hyper HEPA filtration in the office. The other filtration that I use is the extraoral vacuum machine that I invested in. And this machine can be moved anywhere. It's just so noisy, so hard to work with. But now I got used to it. So again, we move it to where I am working, and you can see, I will show you much more in a clinical setting how it looks. So it has a big mouth, which can be close to wherever I'm working, and it picks up all the aerosol. It's like really huge suction, like a big vacuum. It picks up everything from the air. So we use that. And then to clean up, of course, I have the steam sterilizer and the autoclave, and we have the pouches, to clean the instrument. This is sterilization machine that I have, the autoclave. And then when the patient, before seeing whatever treatment I have to do, we use mouthwash, either chlorhexidine or any other mouthwash can be used, which has CPC, either Crest or Colgate, whatever, at least to reduce the bacteria in the mouth. The studies, I saw a statistic with 770 patients, they did a statistic, and it says it reduces the virus or the bacteria by using the chlorhexidine or either chlorhexidine or the Crest, or I mean, it doesn't have to be Crest, anything which has like 0.07% or even 0.05% of CPC. Any mouthwash will reduce the bacteria virus in the mouth. So the aerosol which is generated doesn't have that much harming bacteria or virus. That's proven. It reduced like 80% of the bacteria or virus in the aerosol. So I recommend using mouthwash before you start your treatment. And then we use something called a dry shield or isolite. Like we have an extraoral vacuum outside, this is like a vacuum inside the mouth itself. So any aerosol which is generated, it is actually sucked inside by these holes. You can see these holes over here. It sucks up not only the aerosol, it sucks up the water, everything. So it doesn't get a lot of spray outside by using these dry shield or the isolite. Because we do quadrant dentistry, one quadrant, and you can work the whole quadrant, and it's also very nice. I love these when I do composite, where you need a really, really dry area with no contamination. So for many areas where I really can't use a rubber dam sometimes, then I use the isolite. And then, of course, rubber dam is always the best to reduce the bacteria in the aerosol. So I use a rubber dam a lot, but sometimes we like scaling and root planning and prophies, you cannot use rubber dam. So then comes this isolite. I use this so that it can pick up all the aerosol inside the mouth, and the extraoral vacuum picks up everything which is outside, which comes. Yeah. So the rubber dam. And this is the way that it's done inside. You can see I have my shield, my loose, my mask, I have my gown, my gloves, and then the extraoral big vacuum is so close to the mouth. My assistant also has the high volume evacuation. You cannot see clearly over here, but this is the image. Like we have the isolite, which I showed you. I have the high volume evacuation also, and extraoral. The saliva ejector, I mean, I'm okay with it, but that doesn't pick up aerosol. The HV, of course, picks up the aerosol. So these are the stuff that we do to reduce the bacteria in the aerosol and to reduce the aerosol itself in the surrounding where we work. So this is when we are working with the patient. Just to sum it up, we have barrier protection, mask, gloves, and eye protection that we talked about, the PPE. We use that. And then the purpose of the mask, especially anywhere where you have aerosol, I wouldn't even enter the room without the mask on. Even if you're talking to the patient, even if there is, like, let's say I just finished scaling and root planning on the patient, which had a lot of aerosols at the time when I was there. And then I'm going to give post-operative instructions to the patient. Now I don't take off all the stuff to give the instructions to the patient. I still have my PPE and my assistant still has a PPE. We don't remove everything to talk to the patient. We still give the instructions with the mask, with the shield, and because we are still staying 6 feet close to the patient, even if we are not, away in the room, we are still close to the patient. So we still don all the stuff, and the room, the aerosol still has the bacteria or virus. As much as we reduce it, there is still some particles because my HEPA filter is running behind there. Still, it's not like 5-10 minutes yet before we let the patient go and the room is cleaned again. So we never take the mask off whatsoever inside the room. We take the mask off only if we have to use the restroom, or it's like, and we have designated areas, and we follow the same protocols that I said to take off all the stuff before we go to the restroom or to eat or whatever it is. So it is proved that when you wear the mask and when the other person also wear the mask, like after the treatment is done, the patient wears the mask right away. Even when the patient is sitting in the room, the patient wears the mask. When we talk with the patient, until I'm ready to start something in the patient's mouth, the patient still wears the mask and we still have the masks on. So it is proven like it's like 1.5% of transmission is so low if both the parties wear the mask. If one person wears the mask and other doesn't wear the mask, there's a 60% chance of spreading. So we recommend, have masks all the time. And if both the persons don't wear a mask, there's a 90% chance of virus spreading. So if both the people are wearing the mask, there's only 1.5% chance of transmission. So all the time, no matter what, we don our mask. We don't remove it. Yeah. So that's the barrier protection. Then, of course, like we talked about, mouthwash with chlorhexidine or any mouthwash which has a CPC of 0.07% or even 0.05% is plenty enough from all the studies that I was watching. Then, of course, we have the high volume evacuator and we have the filter which is running. I don't have the ultraviolet treatment because I did some study on the ultraviolet treatment and it didn't have good, the results were inconclusive that it is actually reducing the virus or the bacteria in the aerosol. So I did not buy the one with the UV system. I just have the hyper HEPA. So, right. So to sum it up, we have the face shield, we use the mouthwash, we wear the gloves, we have the mask, I use a rubber dam, I use the hand sanitizer, we use a paper towel, we use the hand soap, thermometer, and surface disinfectant wipes, isolite, dry shield, air filtration, we use the extraoral suction, of course the gown, the safety glasses, sterilizer, and that's the extra oral suction over here. Some of them wear the bonnet, and for the leg they wear the covering for your shoes as well, but I just didn't think that was necessary because I have the shield which goes a little bit above my head to cover, and the leg, it didn't matter because anyway, every patient we can keep wiping the floor. We do it only once by the end of the day. So I left the floor as it is. So this is another electrostatic fogger that is available in the market. I do not have this because it says it releases the hypofluorous acid HOCl, and it's even though it's a mild acid, I have some very huge, very good expensive computers in my operatories because we do intraoral scanning for our crown and bridge. I don't take impression, I use a scanner, and I need a really heavy duty computer. And I was, if I use a fogger or electrostatic, to have the HOCl, I didn't want anything to happen to my computer. And the results, when I studied, if I thought that it was really necessary, I would have bought the fogger. It's not very expensive than all the other machines that I got. But the results were not super good results, showing that the fogger works very good to reduce the bacteria or the virus. So the statistics didn't tally as good for me. So I did not buy, and I'm not using. But if anybody else over here is using and have good result with that, if they would share, I'm willing to take the bet unless it doesn't affect my computers that I have. So this is after, now we are done with the patient treatment, right? I mean, like we saw how before even the patient comes inside the operatory, then they sit in the operatory, we do the treatment, and after that they have to leave. So what do we do when the patient is exiting the office? So we have the patient entrance over here. I don't know whether anybody can see it because it's I have a patient entrance and a male entrance, separate doors. So the patient entrance, the patient goes inside. They wait in the parking lot until we call them to come inside. And once they come inside, they go to the waiting room where they don't sit anywhere. Like you saw the plexiglass where my staff gives them the paperwork, and they fill up the stuff, and then they are brought directly to whichever room is available, either room 1, room 2, room 3, room 4, room 5. So whichever room is ready for them, we have a plan already for them. So we say, okay, this patient needs to go to room 2. We have a good communication between my front and the back office. My lead back office knows to say, okay, this patient needs this much treatment and this is a better room, so we can take them to room 2. So the patient goes directly to that room, and once the patient is done with that treatment, then they follow the exit outside. So if the next patient comes in before this patient is exiting, then they don't even have they don't even see each other. So they exited in a different way, and it's just a one way. So there's no cross path between anybody in the office. So we have another exit for males only. So again, the mail comes and then it's stored in one place, and my staff wipes and cleans before it can be taken to wherever it needs to be stored. So this is like, we created like a one way, so we don't clash on each other, and we are not 6 feet close to anybody. I don't know why it's not okay. So now we're done with the patient leaves, right? So when the patient leaves, if the patient develops symptoms after 2 days after leaving the clinic, they call us and let us know, hey, we developed symptoms. So when they develop the symptoms, then we have to quarantine ourselves or protect ourselves, or whoever. I mean, most of the time, another patient is not in contact with this patient because, like I said, we have strict protocol. My staff knows that they cannot see each other, they cannot be within 6 feet of each other. So they come one way, they leave one way. So it's basically my staff and the patient who actually interact with each other. So what we do is, again, we follow strict protocols. So everything, we have mask, shield, gown, everything, even before we even come in contact with the patient, so that we are all protected. So for example, if we have a staff member or a staff member's family, they are tested positive. So this is what we have to do. So if they're confirmed positive, then they self-quarantine for 14 days. But if the patient is not, not the patient, the staff member is not, they don't have any symptoms, but you suspect. So we perform a staff exposure risk assessment. I will show you in the next slide what is that. And then if the household member has been tested positive, we recommend them to self-quarantine if they develop symptoms. If they don't develop symptoms, again, we do the risk assessment and then bring them back to the office. So again, if they don't develop symptoms after the 3rd day, I have not bought it yet. I just bought it. I'm planning to do the test by myself in my clinic, so that I don't be, it's like so short staffed to work with less number of people, especially now we have to do more work to clean the rooms and, to manage the flow and stuff. And if like one staff member or two staff member is home for like 14 days, that means like 2 weeks, we are down with two staff. That is too much confusion and chaos in the office with two staff member less, and too much workload on other people who are working. So I have ordered the test, which you can test it with a finger prick and see in 10-15 minutes whether they are positive or negative. So if they are negative, of course, after the third day, I let them come back to, I'm planning to let them come back to work. So that's what I'm planning to do. So the next is we perform staff exposure risk assessment. So that is, it's very easy. If you're wearing your whole PPE and you're not, I mean, we are 6 feet close to the patient when we're working. But if you have your whole PPE and if you're following good washing hands technique that we talked about, then there's no work restrictions for my staff. They can continue working until they develop symptoms or if they tested positive. So that is low risk for the staff member. But if it's like high risk is people who didn't follow instructions and who are not using the PPE as it needs to be used. So if they didn't follow the instructions, then of course, they stay home, they don't come to work for 14 days, and that's what it is. So that's the reason why I just had so many issues with staff member with, so I really wanted to get the test in office. So this is the low risk and high risk. So if you wear proper PPE, you're at low risk with anybody because the virus is transmitted with droplet and, with aerosols. So it's, if you have good PPE, you don't have to worry. So this is a test I was telling to you about. There are two types of tests. One is the saliva test that you can, with the nasopharyngeal, test that you can have. The other one is the blood serum test. This is the antigen test and the antibody test. So there are two tests. And I didn't want to wait for the saliva nasal. It's 100% accurate, but I didn't want to wait because it's like a 72-hour wait to know whether we are positive or negative. So I just wanted like very quickly to know, hey, I'm positive or negative, whether she can work today or whether I have to send her back home. So I found this IgM with 99% of success rate. That's what it says. And within 10 minutes, you will know whether the patient is, if not the patient, my staff, I'm planning to do mainly for my staff and myself, is positive or negative. So we go from there so we can work with more work people in our office. So, and this is a consent form I have for my patients. It's like, with all the stuff which is going on, I have this telling them, there is no guarantees. It's like we take all these precautions. I've invested so much stuff and, it's like we do so much to protect the patients, the staff, everybody. But still, you don't know when you're going to get and how you're going to get with this. So, we just have this as a liability, telling them, if something happens, it happens. Yeah. So, good. And Dr. Manohar wanted me to go over some biohazard waste. That itself is a full topic by itself. But I just wanted to go over what I normally do in my clinic. So the biohazard waste is mainly the infectious agents or any organic tissue. Can you see? So, infectious agents or organic tissues from extraction or liquid waste from blood. I do PRF, the platelet-rich fibrin, because when I do surgeries, I want it to heal faster. So we have a lot of blood which is collected. We need something, we throw that. So that's why I have that goes into the biohazard waste, and we have sharps, needles, scalpels, everything goes into the biohazard waste. So this, we ship it to a place where it's like a cremation, they burn it. And we don't do this in the office. We just put all the stuff in the biohazard waste. So the old teeth also can go, the old crowns, it doesn't matter. Most of the time nowadays, the crown breaks anyway when we work. Yeah, so that's for the waste. And then the other waste that we generate is the amalgam, the old amalgam. I don't do a lot of amalgam nowadays, but whatever amalgam, we take it out of the mouth. Then we have the amalgam separator. So the amalgam separator collects all the amalgam, and this also, once it is full, we pack it up in a box, and then we send it outside to a facility where they dispose it for us. So this is the other biohazard waste we dispose of. And I don't do this anymore. I have all digital, my office fully digital, so we don't have X-ray chemicals. Before, I used to have X-ray chemicals, one for developer and one for fixer. Again, we store it, and then we have a company which comes and picks up all the fixer and developer. And we have solid waste. That is just trash. Like I showed you, the plastic, which is too much generated now. It's all trash. We don't have a choice. I tried to recycle, but I got a call from the recycle company saying that these plastics cannot be recycled. So it is now all fully trashed. All right. I think I took the whole hour almost, but I'm still open to questions. Hello?
Yeah, hi, Dr. Anandi. Is that done for you from your side?
Yes, I'm done from my side. I showed, what we do
Yeah.
before, we do during, and we do after.
Yeah. Thank you so much for the wonderful session. You have taken a lot of time in preparing all these things. And thank you so much. The odd hour you have been sitting up and sharing your presentation with us. I request the participant to ask. The floor is open for discussion.
Questions? Yeah,
Yeah,
definitely.
questions. Anything you would like to ask? Dr. Anandi is Indian by native, so you could freely talk to her and ask her.
I
She
hope
will
it was
understand
clear
what it
in
is like
whatever we
in
do,
India.
right?
Yeah, tell me.
Was it clear enough?
Yeah, very clear, very clear, very clear. I think so. From everybody, it was clear.
And I know people are nervous and scared about, I should tell you the story. At first, end of March and April, I was a little nervous to go to my clinic. It was fully closed actually, because my government over here wouldn't allow us to go to work. We had to do only emergency services. And I worked like a couple hours a day. So even to go out and see an emergency patient, I was very nervous. It was so much anxious. And it was like, because you hear all these stories, people dying here and there. And it was like, do I really have to go to the clinic? I don't really need this money, that kind of thinking goes in your head. Then I still went, because I do have patients who are, I care about, and they have pain and I want to go help. So I went to help out some of the patients that I know when this COVID came. And the way I handled the patient was not the way I was. I'm not the person who really goes in, talks in like 2-3 minutes and comes out of the room. I stay there, make them comfortable, talk to them, make them understand everything that goes on and what I'm going to do. I spend quite some time talking to them before even I start the treatment. So when the COVID times, I probably talked for like 1 minute to the patient. I went to the room, checked their medical history. I asked them to open the mouth, and I gave them antibiotics, and I left the room. So it took me like, 2 minutes, because it's an emergency. I'm not looking at the whole mouth, right? And one of the patients is like, is Dr. Anandi all right? you know, why, how is she feeling? You know, she asked my staff member this question. You know, that's when it hit me that, you know, that I'm being a victim over here rather than finding an opportunity to help the patients. I felt like I'm acting as a victim and not taking control of what needs to be done. So after the patient told me that, I came up with a plan. I was like, no, this is not right. This is not me. Why should I be nervous and why should I be scared of doing what I love to do? This is what I do every day. You know, my husband tells me I work from 8 to 8. So that's what he tells me. So it's like, this is where I live. And I shouldn't be scared. I should be nervous of what I love to do. So I came up with a plan. That's all you see, all the research that I did to, you know, help my patients. Now I'm back to, even with all bearing, you know, I spend enough time with my patients to talk. I felt like she opened my eyes. It's like, you know, this is not her. I was like, yeah, she chose me to be her doctor. So I should be the same thing. I should be as courteous as to my patients because she chose me. She gave me the power to heal her. That's how I felt that day. So I just wanted to share how I came up with all these plans that I came up with. So if you're scared, that is normal. Get over it, form a plan, go to your office and do your protocol with due diligence. I'm not saying be stupid, right? I mean, like, follow all the stuff and, you know, it will work out good. Yeah. Thank you for listening to my story. Yeah. Do they have any questions?
Sir, you're on mute, sir. Manohar, sir, you're on mute.
Very true, Dr. Anandi, and thanks for sharing that. And I feel that's quite an encouragement for all the practitioners over there who are very apprehensive and drawn into their shells. How is the institution level practice over there? How are the institutions doing? Are you aware of how is the institutions handling these things? Are they into practice or they are avoiding patients?
You know, I still have a lot of my friends who haven't opened clinic as much. You know, they still do only emergency treatment. And I have short staff because, you know, some of them are sick. I have to send them home. And because of that, I started hiring more people actually from people who don't have work. They actually come and ask me, oh, can I work for you, Dr. Anandi? You're open. You know, my office is closed. Can I come and work for you? That's what they ask me. And, you know, I'm happy to say that, you know, again, like I said, we follow protocols. I'm not just doing just because, you know, we follow protocols. And like you said, there are a lot of offices which are not open full time. And yeah.
What about educational institutions like schools, dental schools?
The schools are not open. They do online courses, if that's what you're asking. But I think they still have their dental division, you know, doing emergency treatment or some type of less treatment. But the schools are not functioning.
We got
They do online courses.
yeah, we got a couple of questions from the participants.
Okay.
Is air purification a must in every clinic and our day-to-day practice? Air purification, is it a must?
Like I said, the aerosol, the HEPA filter that I bought reduces the bacteria and virus by at least 60%. You know, if you're generating aerosol, I do recommend getting some type of air purifiers. They're not, you don't have to get the very expensive one, but at least a simple air purification system will do to look at your the cubic feet and how much you need, how much time you need to give. But I do recommend using air purification system if you're generating aerosol.
Hello.
Yes, somebody is wanting to ask a question.
Yeah,
Yes.
Rajkumar here, sir.
Yeah,
I want to ask the use of UVC lights in the clinics because we are after seeing few articles, we all bought UVC lights and installed it in our clinics, thinking that it's very effective. But she said the effectiveness of the UVC light is not very good. So I want to know more about it. If there is a support of literature support.
I only read the American Dental Association they are the ones who said the UVA, B, and C, that is not really recommended. And I'm following what the American Dental Association, we have what they recommend. I am following that. And they did not recommend, and the studies that they had on the journals didn't show me that it was needed. So these are the stuff. I'm not saying I know everything. These are the stuff that I'm following. I did my due diligence. I did my research, and this is what I came up with. I'm not going to say it doesn't work because I really don't know. But because the American Dental Association doesn't recommend that, and they say it's not as great in doing what it's supposed to do. So I didn't want to invest in that. So I didn't buy.
Thank you, ma'am.
So in your setup, how many patients you handle per day? Or you said 8 to 8. It's almost a 12 hours.
I mean, I don't work 8 to 8. He just says that. I start at 9 to 7 is what I work.
9 to 7, yeah.
But anyway, he includes my driving time. So, but every hour we have at least like 3 patients. One is for ortho. I have like 3 lines of schedule. One is for ortho. I don't spend too much. I have a staff member who can change my wires. Legally, a staff member can do that, who has training. So all I go inside the room and tell them what to do, which takes like 2 minutes, and then I leave the room. And then the other schedule is for me to do some type of treatment. And another area is where they need x-rays or some type of diagnostic work. They need bite or so, which my other staff member can handle. So I'm mainly in only one room. The other 2 rooms are just like quick checkups, 2 minutes here, 2 minutes there, but mainly I'm in one room. So every hour we have like 3 patients, basically.
There are 2 questions. Can you elaborate on oximeter, the role of oximeter in our field?
The pulse oximeter?
Yeah.
All right. I do have that. I haven't implemented so much because I haven't done too much study on that yet. But I heard it is a good indicator, to check on COVID. I recently purchased it, but I haven't actually implemented it. So I'm not. That is one of my to-do list next.
One more question is there. How efficient is the extraoral suction?
It's really very it's like unbelievable. I mean, like you can actually feel the pressure. Sometimes my hair even goes inside the suction if my hair is not fully tied up. So I mean, we do have hair to be tied up, but when I first started using it, I was like, I wanted to see the power and stuff. So we turned on the machine. I went close by, and it was even pulling my hair. So it's really very, very, very strong. Yeah, the extraoral suction, I would recommend that.
Then one more question. Does inline Clorox water treatment reduce aerosol transmission?
The inline filters, we do have the inline filters. Mine has iodine in it, not chlorine tablets. I have iodine in my inline system. Yes, it does reduce the amount. I mean, it doesn't reduce the aerosol. It reduces the bacteria or virus in the aerosol. Yes, definitely, because it is chemically treated, right? Yeah.
Any other questions from the participants? You want to ask or you want to type? You could type. I think if nothing is there, we can, I'd like to say heartfelt thanks to you, Dr. Anandi. That was a very bold presentation, and they say, something to hear.
I know it's a dry subject. I normally don't, I teach only orthodontics mainly and occlusion, right? This is something new I had to come up with because Dr. Manoharan asked me to. So thank you.
Thank you so much. They say, something from the horse's mouth. We are listening directly from that. So somebody, a bold practitioner who knows stuff and uses it judiciously. That's what we want to hear. And I think justice was done to the topic. And in token of appreciation, we'd like to share a certificate which will be sent to you through email to you. It's a humble token of appreciation. a certificate.
Thank you.
Can you share? You shared it? Can you see the screen?
You want me to stop the share?
Yeah, if you stop it, you
Okay.
can see it. Can you
Yes,
see?
I did.
Yeah, that is
Thank
from
you.
our university to you, a humble token of appreciation. Thank
Thank
you
you.
so much, Dr. Anandi. And I request all the participants who are present to fill in the Google Forms so that you will be getting your certificate of participation too. And there are a few questions which are asked by the speaker. I think it's mandatory for you to answer that to get the certificate. And we'll be having Dr. Anandi again for one more session.
Yeah.
On condylographs. If anybody is interested, you can log in. We will post it soon about the advertisement or the promotion brochure. Anything else you would like to tell, Anandi?
I think I
Yeah.
told my story
Yeah.
already.
Thank you so much.
So
Thank you.
yeah, don't be scared. Everybody, don't be scared. It's just, it's there. You can't do anything about it. It is what it is. We just have to not be a victim in it. Find the opportunity and, be safe. Follow again, if you wear a mask and if the patient wears a mask all the time, only take it off to do the treatment. There's only 1.5% chance of transmission. It's very, very, very low. So don't be scared. Go ahead, do what you love to do, right?
That's very reassuring. And and there are almost 215 participants at one point. So it's quite a number. And they all have appreciated in the chat box also about your presentation. However, we'll send you the formal feedback to you.
Thank you.
After this. Thank you so much. Nice having you.
So I'm done. Can I close?
Yes, we are done. We are done. I will end the session. Shall we end the
That's what
session?
I'm asking. Can we end the session or do they have more questions or no?
No, I don't think so. They are having any more questions. They are saying thanks. A lot of thanks are coming. Very informative.
Thank you. I can't see anything over here. So thank you all for listening to me, right?
Yeah. Thank you, Dr. Anandi. See you.
Thank you.
See you soon.
So send me the
Feedback.
yeah.
And that's it.
Yeah, I would really appreciate it. Give me 10 thumbs up, right? Thumbs up.
So Ma'am is asking for thumbs up from the participants, please.
Right, from everybody. I need thumbs up. Thank you all.
I should see a lot of yellow thumbs here.
Thank you. I really appreciate you guys. Thank
A lot
you.
are coming. That's the actual Dr. Anandi. She is very cool. So far we saw a very formal Anandi. Yeah. Thank you so much. See you.